Thank you for tuning in to our Swansea Bay Full Stop podcast series, part of a big conversation and talking all things falls prevention. Falling or fear of falling affects millions of lives every day, but it does not need to be an inevitable part of ageing, and falls prevention is everybody's responsibility. So let's start the conversation and see what each of us can do to reduce these risks.
Hello everybody. Today I'm really pleased to introduce two clinical lead pharmacists. So we've got Lorna Pierce, clinical lead pharmacist out in the community with primary care, and Sheridan Court, clinical lead pharmacist in the inpatient setting here at Swansea Bay. Both bring a wealth of experience and knowledge, and we're talking today about how medication can possibly affect falls. So I thought, start with, why is medication an issue or worth considering as a possible cause of falls?
Falls can occur for a lot of reasons, and if we think of some of them, so potential reasons like feeling dizzy or drowsy, maybe your vision becomes blurred, or perhaps, somebody's just collapsed, and that could be because of blood pressure issues or anything to do with the heart or being quite sedated. Again, all of these reasons are why people fall. And potentially all of those reasons could either be caused or be contributed to by medications as well. And obviously as we get older, we're more prone to these effects of medications and side effects. Potentially one reason could be that, you've collapsed because your medicines have contributed to that. And also, if we've got a shed load of medication to take every day, they can have additive effects as well and make the chances higher of these things happening. So it's definitely worth thinking about our medicines involved.
You touched on it there with the number of medication. When we talk about, if we're thinking of falls are more common in our elderly population, the majority of them are on multiple medications, polypharms, talking over 8, over 10 medication. And that can all add together to increase the effects of these medications and contribute to falls. Looking at other things, Sheridan touched on sort of blood pressure and dizziness. It's things around blood sugars as well. Are they on medication that affects that? What's their diet like? All these things contribute together in our population and can increase the risk of falls. And as human beings, we are all different. So how one of us reacts to a medication is not going to be the same as everybody else. So, it is a really important factor to consider when we're thinking about falls.
Everybody reacts differently. Some people are more sensitive. Some people need more to have the same effect. And that's where your skills and knowledge as pharmacists is so important, because it does affect everybody so differently.
If they've come into a hospital setting as well, if we're thinking about that, something's obviously made them acutely unwell to be in hospital. Is there elements of dehydration going on? Is there some infection which can all again affect perhaps how well our kidneys are functioning, everything else, which can make the effects of medication all the more then.
It's amazing how much of an impact it can make. And obviously medication is there to make us all feel better, but it's about having that knowledge and that understanding that possibly we need to look at the medication specifically. So are there some medications that are more likely to cause falls than others?
Probably say the short answer is yes. And just following on from a couple of points we've just said, really, that most of the time, a lot of the reasons why we fall because of medicines are either for sedative reasons. So are they making you drowsy, making you dizzy, and also things that affect the heart, or the circulation. So drops in blood pressure, drop in heart rate, having problems with your heart because of too much medication. So any drugs basically that can do that. And if you're on multiples of the same drug that has the same effect, that all do the same thing, then the likelihood of them causing problems is a lot greater. So yes, there are certain drugs that we would keep an eye out for, especially if somebody's already fallen.
And I think with a lot of these drugs, unfortunately, they are some of the most commonly prescribed drugs, especially if you're thinking about frail elderly, medication around for the heart, for the blood pressure and conditions such as that. So they are commonly prescribed, and they do have some of the reasons that patients do fall, and the sedative effects as well. One of the most common complaints in our elderly is around pain and pain relief, and the use of analgesics and opioids, and all of those things can increase sedation and increase the risk of falls. So they're drugs that we see every day, that there's nothing really unusual about the medication, but they are the ones that are at higher risk of falls.
You talked then about people coming into hospital. There are certain medications that would warrant you to have a bit of a closer eye. So if someone is coming into hospital and they're already at a risk of falls, what is pharmacy's role at identifying those patients, and what are you looking at when it comes to the medication?
When somebody comes into hospital, my first approach is to have a look for the reasons why they've come in. And then my second protocol is to try and think about, okay, so has this admission either been caused by, or is there medication that this person takes that's contributing to the reason why they're here? So, for example, if they've come in with a fall, as part of the multidisciplinary team, one of the pharmacists or the pharmacy team would look into the drugs and actually think about what are the high-risk drugs here? Are they still needed? So lots of people have been on medications for, years and potentially have never seen a doctor within a long period of time. So perhaps they're on medication that's not needed anymore, or the evidence isn't there to back up what they're on anymore, and actually there's better alternatives available now. Part of that team, we basically have a look at the drugs, see if there's any there that have caused the problem, any contributing, and any medication that doesn't have an indication anymore that would contribute to these issues and falls. And as part of the team then, we've got opinions then from doctors, physios, OTs, as to the bigger picture and whether actually taking that medication away would make the situation better then. It's a lot more clinical than potentially what most people think of a pharmacist's role of putting, medicines in boxes. I would say I hardly ever do that. Mine is definitely more of a role of trying to do medication reviews and get rid of these high-risk drugs.
Yeah, I was going to say, I'll come in and say I never put medication in boxes. I'm not sure I've done that in about a year, but obviously part of my role is with the new and up-and-coming virtual wards in primary care. And yeah, it is very much that clinical pharmacy. So, any patients that come through our service, we are looking at, as Sheridan said, so tying up their medication with their clinical background and their medical history, trying to find out why they're on medication. And is it still appropriate? Is it still evidence-based? Is it the best therapy now? Or, like we said, some patients don't see doctors from year to year, don't bother the GP. Has things changed? Is there better medication we can put on? And we complete a medication review pro forma, and we are highlighting those drugs that are an increased risk of falls. So that may be because of blood pressure, sedation, drowsiness, all the things we've just talked about. And those are then our focus on the medication we need to target to see if they're still needed. Can we stop them at all? I think it is important to remember with some medications that can contribute to falls, it's not a process that we can just stop them straight away. If some analgesics, for example, they have to be tapered down and withdrawn slowly, but we would be certainly looking at initiating that process. And just making sure that everything is still clinically needed and the medication, before we start adding in any new medication, can we sort of optimise the drugs that are already there? Because, we don't want them taking more tablets and other tablets that could potentially increase the risk of falls further.
I remember my grandparent just taking the same tablets for years and years. And if I ever said anything, it was like, oh no, I've always taken these. Technology changes, our information, our evidence-based changes, and not always an easy conversation for people when they've been taking something and they've got that trust in a medication that's what's keeping them well.
It is very difficult, especially with certain groups of medication, perhaps analgesia. Yeah, if patients, they've been taking them for years, and it is really difficult to try and explain sometimes why we want to do it. But it is about that education as well, and perhaps not just to patients, but to their wider family as well, who may be involved in their care, to just try and explain our rationale for what we're trying to do and what we're trying to prevent. And I think it's important to remember as well that the patient's clinical picture will change throughout their journey, whether it be in primary or secondary care. So when we, initially review a patient, perhaps we'll make certain suggestions, but then if, they had another fall or another 2 falls, perhaps we would be a bit stronger with our recommendations then and actually say, no, we really, really do need to stop this now. So it's that continuous process really. But I do think, having those challenging conversations, but engaging the families and the patients do generally give us better outcomes, and they're generally more on board then with what we're trying to say if they understand the risks.
Just the change in sort of the risk versus benefit profile as well. So we think as pharmacists a lot about this in terms of, if you've had several falls, when you're on medication that could potentially contribute to that. but you're also on the medication for another reason, we kind of sit down and think, okay, so how much benefit are you getting in terms of what we're trying to treat versus the risks of these side effects causing falls? You know, and if that greatly outweighs your benefit, you're almost tipping the scale then in terms of, are you better off not being on this medication than being on it still?
We're talking a lot about medication here that can cause falls, but it is important to remember as well that some medications, while they might not directly cause a fall, by being on a certain medication can sort of worsen your outcomes if you had a fall. So if you think of things like long-term steroids, some antidepressants, you know, they can affect sort of your bone density and that. So it would be your increased risk of fractures. So perhaps we'd be even reviewing medication like that. So although they're not perhaps going to directly, cause you to have a fall, they would cause, worse outcomes then.
And that's really important, isn't it? Because we know that people, if they do fracture, their outcomes can be really quite impactful. So we need to do everything we can to make sure that that's limited. You obviously can't see people all the time. So what can staff or carers do to highlight and recognise the need for perhaps someone like yourselves to come in and review medication?
From an inpatient point of view, any professional really that's worried, if somebody has fallen or is at very high risk of falls, tell us, because we can look at the medication and try and chip away at potentially any problematic drugs there. If you've got an inkling that, they're not that steady on their feet, or, you're a little bit worried about them, it is definitely worth telling us about it, because there could be a reason we could help with. If somebody's just in general on a lot of medication, and you think, gosh, how on earth is this person coping with all this? A lot of the time there is things we can take away that, are not going to affect, the long-term benefit they're going to get from being on them. Or even things like changes, like if somebody's blood pressure is now very low or their heart rate is low, let us know, and we can advise then medical teams as well on sort of the best antihypertensive to take away. Any worries at all from any professional really that you think perhaps this person does need their medication looking at. I'll blow our own trumpet here, but we are probably the better people to be looking at it.
I mean, the primary care side is probably far more difficult because you haven't got this, sort of almost like a controlled environment with a patient in a hospital bed having daily blood pressures or anything like that. But I mean, there are sort of growing teams out in, primary care now. We have cluster pharmacists, there's practice pharmacists, and obviously we've got the virtual ward teams. So we would perhaps be relying on things like the GPs, perhaps highlighting to a member of the team, that this person has fallen a few times. We've got a care home pharmacy team as well, and I know we're looking at doing some work around with the care homes of how we can sort of be highlighted, patients who are falling or those who are at high risk. A bit around the virtual wards though, any patients that come through that would have a comprehensive medication review. We would do sort of blood pressure checks, sitting and standing, looking for postural drops in blood pressure, so they can be referred to us that way. But it is far more difficult in primary care, and perhaps I guess there's probably a lot of people out there who fall quite a lot and actually nobody really knows about until they actually bother the GP or end up in A&E. So it is far more difficult. But the same thing, if patients are on lots of medications, as Sheridan was saying, or anything changes, or they are falling, their blood pressure's changed, then just highlight these patients to anyone in the team really. Yeah. And I think it's just important to remember sometimes that perhaps, like Sheridan said, we are the expert really on medication. That is our background, and that we're not trying to be obstructive sometimes, because I get a lot of queries of this person needs, a sleeping tablet, or they need something like this. And sometimes we do say, well, actually, no. And it may be because they're, wandering a lot and they've had 5 falls and we don't want to sedate them anymore. And we understand it's really challenging, but we're not trying to be obstructive. We're trying to work, for the best of our patients, really.
For in the community, because it is a bit more difficult for people. If people are listening to this who either feel this is about me, I feel like I'm taking too many medications, or I'm feeling a bit wobbly on my feet, or perhaps a loved one, what would be the trigger for them to ask for that review of medication themselves? How would they do that, I guess?
So most community pharmacists offer a medication review service. So, it could be a first port of call if you use a regular pharmacist or pharmacy. They might be a first point. I think it would be then perhaps going through the GP to see if they can go through their medication and ask, if they can be referred or speak to perhaps a member of the pharmacy practice team. Doesn't necessarily need to be the doctor. It all depends. We are trying to sort of reach out into other teams as well, because there's a lot of community teams out there now, who have a lot of eyes on the patient. So we are trying to strengthen our links with all of these other services so that perhaps it makes the referral process a little bit easier getting through to us.
The only other thing I was particularly thinking about is if somebody has been prescribed a new medication, there are side effects to a lot of these medications. What should people look out for to be able to get on top of any issues early if they are to start something new?
I'd probably say that the majority of the time we see problems in the new medication that's been started, the most recent medication. So, like, for example, if somebody does come into hospital and it's caused by a drug, it's caused by an adverse side effect, it's usually the newest medication that is the culprit. So what I would say is any changes in anything really, it's definitely worth speaking to somebody about it. Obviously, depending on what the medication is, there's hundreds of side effects for each of them. But if you notice a change since, recently starting something, and that could be with anything, that could be, bowels, dizziness, how you're feeling in general, speak to somebody, go back to the person who, advised you to take it, practice nurse, a pharmacist, just go and speak to somebody and just say, since I've been taking this, I've been feeling this way, is this right? Or is this something I should be worried about? And try and nip it in the bud sooner rather than waiting to see if it disappears, because it could, snowball into something a lot bigger potentially. And your local pharmacist is probably your easiest person to have a chat with, because they're open pretty much every day apart from a Sunday. Some of them are open on Sundays, but they're your most accessible person, because you don't need to book an appointment. You can just say, can I have a word with the pharmacist? And they've also, they've obviously got confidential rooms as well. You don't have to have that conversation in the middle of a very busy pharmacy.
They are, open to all these consultations and everything now. And like I said, they are the most accessible people out there. I think in terms, just to touch on Sheridan's point, obviously, if somebody was having a severe reaction to a medication that they just started, then you'd probably be looking at swelling and struggling to breathe. If anything like that happened, you'll be talking sort of 999 A&E straight away. But it's just have those conversations. I always say there's no such thing as a silly question. So, if you're feeling a little bit different or not quite right since starting on something, ask, because we don't want it to snowball into anything worse. There are things we can do, and perhaps, as healthcare professionals, we can advise. So, if somebody is going to be started on a blood pressure tablet, then, recommend they take it when they're sitting down in the morning, perhaps having their cup of tea, and give themselves sort of 15, half an hour before they sort of get up and walk around, just, in case they do get a sudden drop in their blood pressure or anything like that. But yes, it's just ask those questions. And you've got your community pharmacists, and like I said, there's a lot of pharmacy team members out in the GP surgeries and everything now. They know the role is growing all the time, so just ask the questions. And if you read the leaflets, isn't it, with all the side effects, they are enough to scare anyone, aren't they? They tell you you're going to have absolutely everything, and I think sometimes that scares people into asking the question then. Yeah. But there's no such thing as a silly question, and there is always something else that we can try as well. I think some people get a bit anxious sometimes that if this medication doesn't work, then there's nothing else that we can try or use. But there is, but we just need to know about, we need to know about it. We need to know that you're struggling to take it, kind of thing. Yeah,
I touch on that big long list of side effects that comes with every drug, that, every box you get has got that leaflet in it, and, it is literally huge, the list. That list is based off anything that's ever happened to a patient within the clinical trial setting, and sometimes post the drug being available on the market. So, that list is basically anything that's ever happened to anybody that's taken this drug. So that doesn't necessarily mean that if you would take it, all these things would happen to you. It's just there as a source of information, and the manufacturers, legally have to produce that information and make it public. Obviously, it's important to know about side effects, but really, don't be frightened by that huge list. It's just something that has to be publicised, basically.
And I think as a patient or a relative, if you're caring for someone, if somebody's starting you on a new tablet as well, don't be afraid to ask why you're on it, what you're taking it for, and what can you expect from taking it. I think many years gone by, it was very much, we wrote a prescription, these are your pills, and kind of off you go. But we want to involve patients, relatives, carers in that whole process now.
That's so important, isn't it? And I think we've come a long way in healthcare, engage our service users or patients much more in all decision making. And it was very much do this, do that, you'll get better. And actually, people need to understand, take their own accountability and be able to be fully engaged in that process to get the most out of the therapy or the rehab or the medication or whatever it might be.
I would say definitely if you're worried about something, challenge us, ask those questions you might not feel confident to ask, but ask away, because, the way I see it is I'm not the person that's going to end up taking the medication. I'm just offering advice on, all the best evidence and what we've got to back up our decisions. But if you're the patient that's going to be taking this medication, you're 100%, allowed to say to us, I don't really want to do that, or is there another option? Because at the end of the day, you're the person that's going to be taking it. We're not going to be taking it. We're just advising you.
And if you're in sort of the hospital bed, if we go to that scenario, and you want to know what's being taken, ask the nurses, whoever's looking after you, the doctors, because they can always arrange for someone from the pharmacy team to pop along and have a chat with you. And we can, we're able to go through these scenarios and questions with you then. Because, the patient, patient services, they are the heart of what we're trying to do from pharmacy in terms of medication optimization, our reviews, our clinical pharmacy service, the patient's at the centre. And like I said, no, we are unfortunately not all robots. We all respond very, very differently. So we need, as part of that whole process, we need the thoughts and the opinions of the service user as well. And that, we've got all the guidelines out there, that we can use, and it can guide our decision making. But we really need that, sort of that relationship as well then with the patient, so that we can achieve the best for them. Because, we can talk all we want about medication and taking medication and falls, but, half the battle sometimes is if the patient's not on board with why they're taking something, they're not going to take it anyway.
I would just say if you're on a lot of medication and you haven't had a medication review, please ask to see if you can have one. Whether that be if you've come into hospital and actually think, oh my gosh, more medicines are being added. Can somebody have a look to see if all these, are still relevant? Do I still need to be taking all of these? Please ask. And the same in community, if you haven't seen your GP for a while and you're on lots of medication, please ask to see if you can get a review. Because like we've mentioned, things change. Our guidance changes. The way our bodies are changes over time. Things that we might have been concerned about, 10 years ago, we're now not that concerned about, and we don't need that much control of it. So like blood pressure, for example, the older we get, our blood pressure targets actually widen. So we're not so tightly controlled with that anymore. So yeah, things change. And if you haven't had a medication review, please ask and have one.
If you're concerned about anything, if anything's changed, if you feel, you haven't had anyone look at your medication for a long time, out in community, approach your community pharmacist, approach your GP surgery. Because like I said, not just medication and evidence changes, but ourselves, as our bodies, unfortunately, we all get older. And like Sheridan touched on, blood pressure, if we look at diabetes and blood sugars as well, the older we get, we're less strict with things like that as well. And so just ask the questions, reach out to your healthcare professionals around you for a review.
So that's the end of this episode. We hope it's provided some useful insights, and please follow the links provided for more information. But remember, falls are not inevitable. Together we can make a difference. Let's keep this conversation going.